lectures lined up. The first is about the dual antiplatelet therapy, DAPT, in ACS. The second is on lipid lowering, how low is too low. Right. Now what about the first lecture? Why should we ever have a DAPT option? We all know that CT, coronary thrombosis, which was coined in 1911, I think, by an American physician. And the major treatment option would be when we started our life, probably learning about coronary angiogram in 1951. We were using both after bypass and after angioplasty in 1980s. We were using only aspirin in 75 and mostly 150 milligram. They were all doing well. But science always evolves in such a way that every time there are the number of deaths is not reduced sizably. We would like to find out what is the cause. If rethrombosis is the cause, why not we add one more antiplatelet drug? And then came ticlopidine. Unfortunately, it did not stand the test of time because it produced a lot of thrombocytopenic purpura, thrombocytopenia as such, and therefore bleeding disorders were more. And then came in late 1999, I think, clopidogrel came into market. And then clopidogrel and aspirin used to be combined from early 2000 onwards. And then the usage of the term dual antiplatelet therapy started coming, which is supposed to have reduced the incidence of rethrombosis after an ACS. Whether the patient has undergone a bypass or he has undergone an interventional procedure, PCI, the incidence of recurrence of thrombosis is reduced when we started using dual antiplatelet therapy. Then came a lot of other drugs to be combined with aspirin like pasugrel, ticagrelor, and all these things. And today it is a blood thinner world. Just before starting off the meeting, I get a message from one of my young patients, 35-year-old patient. Sir, should I have to take a blood thinner? I have just recovered from COVID. So everywhere blood thinner. And people who are going for injection, they are asking, sir, should I have to stop blood thinner? I do not know. Somebody wrote an article, blood thinners should be stopped, without knowing the difference between warfarin group and the antiplatelet drug that we use. Unfortunately, everybody asks. Every one of us will be getting 100 calls every day. Sir, should we have to stop? So blood thinners have become probably one of the most prescribed drugs in the world, and it is going to be the most prescribed drug in the presence of COVID also. So how well do we use the dual antiplatelet therapy, especially in acute coronary syndrome? To add on to our armamentarium of treatment in ACS, they have started using another drug now, which is a DOAC or a NOVAC. And in what situations do we combine clopidogrel with a DOAC? That is directly acting oral anticoagulation. That is the theme of today's lecture. And to moderate that, we have a chairperson and a moderator. Chairperson, I will introduce, that is Dr. Muralidharan. If you want to be a cardiologist today, you can be an armchair cardiologist doing only ECG, probably treadmill also, and also echocardiogram. And then if you want to do only intervention, you can be a catheter-feeding cardiologist. But if you want to be a more and more of an interventionist, you can be an electrophysiologist. But you want to see all-in-one, that is Muralidharan. He is not only an all-in-one cardiologist, he has taken training in every field of cardiology, and he is also a great teacher, and teacher for many of the present-day younger generation cardiologists. And to welcome him, I have the greatest pleasure, because I have been associated with him for nearly 3 decades. And I always appreciate him, both from the distance and from near, that he is a wonderful cardiologist, continues to be one. And he has got a team whom he will introduce. Thanks. Murali, you can start.
Thank you very much, sir, for your kind words. You are always kind to me throughout my career. It was my pleasure to be known to you and to be your friend, junior, a loud person. He was quoting this Quran some time back. I don't know how many of the people in this Zoom meeting are on Tamil forum. One Quran is Tammin Periyar Tamara Olugal Vanmairallam Talai. That means when you are going to any field, the best character you can have is identify somebody great in that field already. Tamir Periyar, Tamara Olugal, go seek them, be friendly to them, learn from them, go forward. So naturally, NSK sir will fit into this. Then I entered Chennai also. Tamir Periyar, it's you only, sir. Thank you for your kind words. And now it's my pleasure to say a few words about this program. Sir has already nicely given an outline of it. I'm going to invite Dr. Prabhakar for this hot topic. Can we put the slide of Dr. Prabhakar? Prabhakar is a very good friend of mine, a leading cardiologist, a wonderful academician also, and an interventionalist. One thing that always makes me to admire in him is the way he looks at the article, looks at the topic, looks at the guideline, the vociferous way he puts his points, great evidence. So every meeting when he comes in, I used to learn points from him. So it's aptly has been placed for this particular thing where though guidelines say something, the practice says something, always a confusion, which will be clarified by Dr. Vinodkumar soon. So my pleasure to introduce Dr. Prabhakar, interventional cardiologist from Apollo Group, well known to everything, and his contribution during this COVID time is immense. And special thing I would like to say, he has a wonderful son, a great musician also. We always get enthralled because he has brought music in medicine in because of his son, and he, of course him also. It's a great pleasure because we are going to have a musical evening. Let us start with the musical man, Prabhakar. Prabhakar, the floor is yours.
Thank you, Murali. Thank you. After Dr. Sivakadaksham and Dr. Murali, two very good friends, and Dr. Sivakadaksham is known to be by family. His father and my father are very close friends. I think if you go into nostalgia, we'll miss the topic. But I will take off from where Dr. Murali left. Tamil Periyar Tamara Uludal. Apt is the apt Tirukural. He said not for himself, but to find out the first among the equals in dual antiplatelet therapy. Because Dr. Sivakadaksham clearly made an introduction for dual antiplatelet therapy and the history of it. But where we are today is in a state of big confusion. We have aspirin, which is always there, which is number one, always there. But the position of number one is being questioned because nowadays we are talking about an antiplatelet therapy without aspirin. The second thing that has happened is what next? That is where the Tirukural that Murali said comes into the picture, which is going to be the first among the equals. So we have three. We have the clopidogrel, we have the prasugrel, the ticagrel are coming up. So between these three, what are you going to choose? When are you going to choose? How are you going to choose? That difficult task is what my friend Dr. Vinod is going to do. So Vinod, I will give you the unenviable task of highlighting us of when to start the antiplatelet, dual antiplatelet, how long to continue, and does it go on forever? There are a lot of questions to be answered. I think I'll just leave the floor to you so that we'll have the discussion more towards the end. Vinod, it's all yours.
Thank you so much, sir. It's going to be a great evening, and all of my teachers are here to...
One second, Vinod, your introductory slide missed out.
No problem, sir.
We know this a very good friend, very intellectual friend, and he is the consultant interventional cardiologist at Sri Ramchandra Medical College. He's also got a very good private practice, very vocal, very knowledgeable. Let's listen to him.
Whether my slides are visible?
Yes, sir.
Visible.
Thank you. So, as the note said by Dr. Sivakadaksham, sir, one of my mentors, and my daily guru, Dr. T.R.Muralidharan, sir, is here. And Dr. Prabhakar, sir, whom I admire in most of his talks every day. We can see him in this digital platform nowadays. So, with all three in the background, I'm going to present a few data available with us regarding the comparison of DAPT, what to be choose and which group of population, which drug is better. So that way we are going to see today. So this flow is going to be what is the background, what is the duration of DAPT. If it is a dual antiplatelet therapy, we all know how long we should continue, in which subset, how long we should continue. That is also very important. As Prabhakar sir said, which drug should come after aspirin, whether aspirin should be toned down in certain patients, what should be the drug and what is the dose of the drug What about the special population where these drug molecules are very, very essential? So with a small note, we all know, as Sivakadaksham sir was pointing out, DAPT is always now is a term coined for antiplatelet therapy, where aspirin is firmly fixed as the first agent, followed by the second agent, P2Y12 inhibitors, either clopidogrel or prasugrel or ticagrelor. Or any of these three drugs, when combined together with the aspirin, we call them as dual antiplatelet therapy. Now, what is the real issue is, initially when the Varma stents came, the dual antiplatelet therapy was introduced for 1 month. Then it rose to 12 months. Then with the evolution of DAPT trial, it even went to 20, 18 months, 30 months. Then it came back with the new generation of stents. From the after first generation stents, we had the issues of a lot of stent thrombosis. With the evolution of second generation of stents, now the duration of DAPT for longer period is being questioned, and the duration is getting shorter and shorter every day, every month. Nowadays we are seeing a lot of papers justifying the use for a shorter duration. So, what is correct? When it is correct? What are the guidelines says? Whether it is 1 month, 3 months, 6 months, 12 months, or 18 months. When should I stop? When should I start? All these things we will try to address via the guidelines. As I said earlier, aspirin with clopidogrel or prasugrel or ticagrelor. So the common difference between the three molecules is prasugrel. We need it's not an active metabolite. It needs one conversion, whereas clopidogrel needs 2 steps before becoming an active metabolite. Whereas ticagrelor, as you all know, it's directly an active metabolite. So we will stick on to these 3 drugs, and we will see what are the loading doses, how to give this molecule. Those things we will see right now. See, if you take clopidogrel, the loading dose is about either 300 or 600 milligram. If you go for prasugrel, if you are going for intervention, clopidogrel 600 mg is good. If it is a prasugrel, it is clear cut, it is 60 mg per oral loading dose. When it is ticagrelor, it's 90 mg, 2 tablets, 180 mg is the loading dose. What about the maintenance dose? It's 75 mg per oral OD for clopidogrel and 10 mg with the prasugrel, and 60 or 90 mg first 1 year for ticagrelor, followed by 60 mg after 1 year if the patient requires further dual antiplatelet therapy. But in case of prasugrel, we should understand if its weight is less than 60 kg, then we can consider 5 mg daily. In the center where I get trained in Korea, Asan Medical Center, most of the South Korean centers, they use 3.1 to 5 mg of prasugrel because they consider their body mass index is very less and they don't go for a full dose of prasugrel. So it is weight dependent. When lower weight people, 5 mg can be considered. What about the platelet inhibition? Compared to clopidogrel, prasugrel and ticagrelor do a better job. Similarly, whenever the inhibition goes up, there is a risk of bleeding also goes up with the other 2 molecules. What about the peaking effect? Clopidogrel takes 6 hours. That is the reason why we do a double dosing, about 60 or 600 mg before a PCI. Whereas in prasugrel, the peak effect is attained within 30 minutes. In ticagrelor, it is about 90 minutes. Metabolism, so both the drugs, clopidogrel and prasugrel are prodrugs as we have discussed earlier, whereas ticagrelor is an active drug. So contraindications in acute bleeding is contraindicated. In case of prasugrel, it is contraindicated in history of CBA or stroke, TAA, or history of CAA. But we see in our center, our interventional radiologist, post-stroke, after intervention, he initiates prasugrel, but probably current clinical evidence only indicates in case of bleeding or CV or stroke, it is contraindicated. Prasugrel is class 3 as per the guidelines. Ticagrelor, active bleeding is the contraindication. One of the issues with clopidogrel, what we are seeing is that is patients having genetic polymorphism. About 25 to 30% have this genetic polymorphism, where thereby the effect of clopidogrel comes down. So it is always better to check the platelet reactivity, which we usually do in Ramchandra, before switching over them to clopidogrel. So other 2 drugs, we don't have faced this kind of issue, but in ticagrelor, we should be careful. When you are initiating ticagrelor, with the dosage of aspirin should be less than 100 mg. Currently in India, we use 75 milligram of ecosprin. So generic, we all know DPLAT, PLAT, STOP PLAT. Algorithm of DAPT in patients with percutaneous coronary intervention. See, whenever we are talking about PCI, we have 2 subsets of population. One is stable coronary artery disease. The other one is acute coronary syndrome. So there is always a difference between treating a patient with stable coronary artery disease and ACS in terms of antiplatelet therapy. Whenever you are treating a stable coronary artery disease patient, if it is not an ACS, if it is a TMT positive patient, for example, then the dual antiplatelet therapy has to be, if there is no high bleeding risk, then we can continue dual antiplatelet therapy up to 6 months. Then we can switch over to single antiplatelet therapy. That is, it is class 1A indication. After 6 months, if you want to continue dual antiplatelet therapy in a stable coronary artery disease patient, it is class 2B. Whereas in a high bleeding risk patient, if you are going to put a stent in a stable coronary artery disease, then 1 month of dual antiplatelet therapy is more than sufficient. After that, we can switch over to a single antiplatelet therapy in high bleeding risk patients. Then, whereas in acute coronary syndrome, it is completely different. If it is not a high bleeding risk patient, you give dual antiplatelet therapy either with prasugrel or ticagrelor or clopidogrel along with aspirin for 12 months. When it is a high bleeding risk patients and ACS patients, we can stop dual antiplatelet therapy at 6 months and switch over to single antiplatelet therapy. Sometimes we consider giving dual antiplatelet therapy in ACS subset of patients with recurrent events even after 1 year. Here, the dual antiplatelet therapy, even after 1 year, it is considered as a class 2B indication, where we calculate DAPT score. If it is higher, then we initiate this patient who have a chance for recurrence of events high. We give them dual antiplatelet therapy even after 12 months. So what about when the patient goes for CABG? If the patient has no high bleeding risk, then standard straight away you give patients who are undergoing dual antiplatelet therapy for 12 months if the patient undergoes a CABG. If the patient has a high bleeding risk, if after the ACS the patient undergoes a CABG, then you can give 6 months of dual antiplatelet therapy. Similarly, patients who are ACS undergoing bypass graft to continue after 12 months, if the chance of the recurrent ischemic event is higher, the DAPT score is very high, then consider giving dual antiplatelet therapy. It becomes class 2B. So, what about? We saw ACS patients who are undergoing PCA, where if it is no bleeding risk, then 12 months of dual antiplatelet therapy. There is a high bleeding risk probability, 6 months of dual antiplatelet therapy. Then we saw in CABG, similarly, no bleeding risk, then low bleeding risk, then go for 12 months of therapy. If it is high bleeding risk, go for 6 months of dual antiplatelet therapy in case of ACS. Now we are going for a subset where ACS patients are managed medically without an angiogram. If there is no high bleeding risk, then continue dual antiplatelet here also for 12 months. Whereas if they have a high bleeding risk, chances are high, then continue dual antiplatelet therapy for 1 month. That is class 2A indication. Then after that, switch over to single antiplatelet therapy. Even in medical management, the chance of recurrent event is high. If the patient had a previous MI and there is a recurrent of event, if there is a high ischemic risk, then even in patients who are maintained on a dual antiplatelet therapy, we can consider continuing them after 1 year, after 12 months. It is class 2B indication. Now we are going into ACS patient. What about loading therapy? If it is a non-ST elevated MI, if it is a non-ST elevated MI, pre-treatment with ticagrelor, clopidogrel is class 2A. Unless the coronary anatomy is known, we don't load these patients with prasugrel. Since we have to stop this drug for 7 days before taking the patient for a surgery. Once the coronary angiography is done, if the patient is going for a CABG, then continue aspirin, even don't stop aspirin. To discontinue P2Y12 inhibitor after the loading, if you are going to send this patient for a CABG, then it is class 2A indication. Post-surgery, resume P2Y12 inhibitor as early as possible. Whereas the patient is going for a PCA, then we have options like ticagrelor, prasugrel, and clopidogrel. Ticagrelor and prasugrel are preferred over clopidogrel in terms of class 2A indication, because they have a better ischemic profile. Prevention of a recurrent event is better with ticagrelor and prasugrel when compared to that of clopidogrel. But when the bleeding is considered, if the bleeding is the concern, then clopidogrel is a better choice among the dual antiplatelet. When you are talking about medical therapy, there is no role for prasugrel. We have two options: either we can go with ticagrelor or clopidogrel. Similarly, in the STEMI, you can load either 3 of them, that is any of the P2 vital inhibitor, and if it is going for a CABG, discontinue P2 vital inhibitor, but continue aspirin. It is class 1C indication. Try to resume P2 vital inhibitor, either clopidogrel or ticagrelor post CABG as early as possible. And similarly, in the patients with PCI, you can prefer either ticagrelor, prasugrel, or clopidogrel. When you are talking about medical therapy, there is no role for prasugrel. We have either ticagrelor and or clopidogrel, and ticagrelor is preferred over clopidogrel in terms of class 2A indication, according to ACC/AHA guidelines. So now we saw ACS. What about stable CAD patients who are undergoing angiography? There is to preload them before an angiogram is only class 2B, because if the patient goes in for a CABG, then it is we have to wait on this patient, discontinue P2 vital inhibitors. So it's better to do an angiography, know the coronary anatomy, and then load them on antiplatelet agents like P2 vital inhibitors, either clopidogrel, ticagrelor, or prasugrel if the patient goes for a PCI. In case of CABG, also post surgery, we can load them with P2 vital inhibitors. So as we have been discussing, stable coronary artery disease, no high bleeding risk. If it is a DES, what we are doing, we have to give this therapy for 6 months, dual antiplatelet therapy. After 6 months, continuing dual antiplatelet therapy is class 2B indication. Similarly, when you are talking about DES in a high bleeding risk, what does the European Heart Association says? Similarly, they are also saying when you are doing a DES, continue dual antiplatelet therapy for 6 months. After 6 months, continuing dual antiplatelet therapy becomes class 2B indications. So it's better in a stable coronary artery disease patients. Both American guidelines and European guidelines concur that you can give dual antiplatelet therapy for 6 months, following which you can switch over them to single antiplatelet therapy. But if you feel there is a high ischemic risk for this patient, there is a residual lesions, then you can always continue this dual antiplatelet therapy for one more next 6 months too. Whenever you are talking about high bleeding risk patients, both American as well as European guidelines says we can continue dual antiplatelet therapy for 1 month, following which we can switch over to single antiplatelet therapy. Similarly, in ACS, we have discussed earlier and about in ACS, we all know dual antiplatelet therapy is for 12 months, but in case of high bleeding risk patients, you have to give dual antiplatelet therapy for 6 months. So now we know dual antiplatelet therapy, what guidelines are saying, how to manage an acute coronary syndrome patient at your clinic level, whom we should continue dual antiplatelet therapy. Even whenever there is a judgmental decision to be made, we can use this DAPT score and then decide upon whether to continue dual antiplatelet therapy or switch over to single antiplatelet therapy. A lot of criteria have been used, like age, diabetes mellitus, smoking history, currently whether he is a smoker or not, prior MI, what about whether it is a ACS event or not, whether the patient is in failure, what is the nature of the stent used, whether it is a CABG intervention, that is venous graft intervention, what is the nature of stent material used. All this relates to gives points to the DAPT score. Whenever the DAPT score is more than 2, then the chance of ischemic event is going to be high. There you can continue dual antiplatelet therapy beyond the recommended period. Or for example, if you want to continue even after 12 months, if the DAPT score is high, obviously you can do a dual antiplatelet therapy even after 1 year of therapy. So how long to use? Default strategies, dual antiplatelet therapy in case of ACS for 12 months. After 12 months, discontinue aspirin and continue one P2 vital inhibitor. What about in patients with high ischemic risk? 12 months, you have to continue dual antiplatelet therapy. Post 12 months, either you can continue P2 vital inhibitor as we have been discussing, or you can even switch over to low dose rivaroxaban. That is what our post director Dr.Sivakadaksham sir was saying. After 12 months, there is now not only the choice of dual antiplatelet therapy, but there is a choice of direct oral anticoagulant, that is rivaroxaban low dose with aspirin is also can be considered, or we can even consider a low dose rivaroxaban post 12 months as a therapy model. So how long to use? As we all know, post ACS even 12 months of dual antiplatelet therapy is indicated unless the patient has a high bleeding risk. After 12 months, dual antiplatelet therapy, only P2Y12 inhibitor can be continued. In patients with high bleeding risk, 6 months of dual antiplatelet therapy followed by single P2Y12 inhibitor or aspirin can be considered. Patients who are presenting with concomitant atrial fibrillation, this is a special subset. The patient who has already has existing pre-atrial fibrillation are presenting to the center with atrial fibrillation with ACS, then triple drug therapy are instigated for 1 month. Post 1 month to 12 months, it varies depending upon the patient. It can be individualized whether the triple therapy has to be given for 1 month or 3 months. Post 1 month, it is usually dual therapy with P2Y12 inhibitor with oral newer oral anticoagulant. And after 12 months, if the patient has a persistent atrial fibrillation, then we can stop antiplatelet and continue only newer oral anticoagulants till as a maintenance therapy. What about the clinical evidence for all this? There are a lot of trials for clopidogrel aspirin combination. Yes, we have discussed. DAPT trial gave us an idea that the stent thrombosis occurs even after 12 months. So it is better to continue dual antiplatelet therapy beyond 12 months. This was published in 2014. ISR SAFE clearly showed that there is no major difference with the improvement in the stent platform with 6 months or 12 months of dual antiplatelet therapy. ISR triple proved that triple therapy for 6 weeks, there is no much difference between 6 weeks and 6 months triple therapy, indicating for a shorter duration of triple or dual therapy. Similarly, we know atherosclerosis study clearly indicated that clopidogrel is very useful along with aspirin in case of stroke patients. And among TIA patients also, clopidogrel plus aspirin combination has a very good role, and they have been proved superior to individually given aspirin alone among these patients with TIA and stroke. What about ticagrelor? The 2009 Plateau trial. Now we have been listening to ticagrelor trials, Plateau, for more than a decade now. We all know that ticagrelor group has a better in terms of event reduction when compared to that of clopidogrel. Ticagrelor seems to be a better option than clopidogrel for patients with ACS, whom a early invasive strategy is planned. Now, with a few bleeding risk going up when compared to that of clopidogrel. What about TREAT trial? TREAT trial, see, we all know Plateau trial did not include patients who are lysed with any therapy, either streptokinase or tenecteplase. So they went again with the TREAT trial. It's also a randomized control trial where ticagrelor is introduced after 48 hours among the patients who underwent lysis therapy. And they proved introducing ticagrelor on patients post-lysis also, they are able to achieve decrease in event rates without increasing significantly the bleeding risk. Though there was clinically the number of events of bleeding went up, there was no significantly worrisome bleeding among the group with ticagrelor. So now, even in the subset of population who undergo lysis after 48 hours, initiation of ticagrelor is safer or similar to that of clopidogrel with just a few bleeding events more when compared to that of clopidogrel. Now we have seen trials like TREAT trial and Plateau trial to say clopidogrel, ticagrelor is superior to clopidogrel. What about the real world evidence, where we are talking about always as a clinician we are worried about real world data. Sweetheart registry is a real world data where they studied patients where 45,000 patients were studied with acute MI who were put upon either clopidogrel or ticagrelor, and they were studied for followed up for 24 months. They found that ticagrelor had decrease in primary event in terms of cardiovascular death, MI, and CV events when compared to that of clopidogrel. So ticagrelor found to be superior to clopidogrel even in the real world data in terms of event reduction. So what about now? We know we have powerful agents which can have a better ischemic protection when compared to that of clopidogrel. What about the duration of the therapy? How long we have to prolong this dual antiplatelet therapy? Cure gave us the idea that 22% reduction in clinical events with DAPT. Rotterdam experience also showed 65% of stent thrombosis or decreases with dual antiplatelet therapy. When it is when the dual antiplatelet therapy is discontinued at 6 months, there is an increased risk of stent thrombosis. Duke database also showed that if you discontinue DAPT at 6 months, the chance of recurrent ischemic events are high. All these studies were done on first generation DES. With real now newer generation DES are available, second generation DES are available, where they have become thin strips, polymer-free drugs, stents are available. With the betterment of the stent platform and the drugs being used, now we know newer trials are suggesting that shorter the DAPT trial is also, the DAPT duration is much sufficient, and the risk of stent thrombosis comes down significantly after 6 months duration. Now the newer trials like Philate and TICO are giving us an idea. One is done in Korea and the other one is in US, where they are stopped aspirin at third month, end of third month, and continue ticagrelor up to the 12 months. They found the risk of bleeding comes down when the individually ticagrelor is continued instead of dual antiplatelet therapy, where the ischemic benefit of dual antiplatelet therapy is achieved similarly, but at the same time, the bleeding component, the risk of giving dual antiplatelet therapy for 12 months is also concurrently stabilized by giving only ticagrelor from 3 months to 12 months. These are the trials that checked security, excellent, reset, optimized. They all compared clopidogrel at 3 months and 6 months therapy, and they found shortening of dual antiplatelet therapy is better or non-inferior to continuing dual antiplatelet therapy for 12 months. What about prasugrel? We all know prasugrel can be loaded 60 mg and 10 mg per roll OD. As I said earlier, when the weight is less, you have to go for 5 mg prasugrel. And in prasugrel triton 38, it is compared with clopidogrel, and we found it is beneficial to the population with diabetes. Whereas you have to avoid in certain group of population, that is stroke, TIA patients, and patients who are above 75 years and less than 60 kg. These are the subsets we have to avoid prasugrel. One is less than 60 kg, age above 75 years, and stroke patients or TIA patients. These patients, the beneficial effects is less when compared to that of clopidogrel. So in that subset of population, either you have to go for clopidogrel or ticagrelor. What about ticagrelor Pegasus TV54, which is the subset whom we are talking, is a high subset, high risk patients whom even after 12 months, the chance of having a recurrent event is high. So these patients, whether it is compared, whether aspirin alone is sufficient or ticagrelor lower dose or ticagrelor 90 mg or 60 mg is safer, or whether aspirin alone is sufficient. This trial gave us an idea that if ticagrelor 60 mg is given for after 12 months till 30 months, the chance of reduction of CV events, MI, stroke among high risk population, high ischemic risk population is palpable. So we can try among those patients who are high risk for recurrent ischemic events. We can continue even after 12 months with ticagrelor 60 mg BD. Safety wise, there is a slight increase in bleeding risk of continuing ticagrelor although 60 mg BD after 1 year when compared to aspirin alone. But there is a significant reduction in CV, MI stroke, mainly contributed by the incidence of reduction in MIs. So, as I said earlier, in high subset, high risk patients, we can consider ticagrelor even after 1 year, that is 60 mg, or clopidogrel among the patients who have a high DAPT score with lesser bleeding risk. We can go for DAPT therapy even after 12 months. So, special populations in both male and female patients, dual antiplatelet therapy after ACS is considered for 12 months. Whenever the bleeding risk is high, then consider 6 months of dual antiplatelet therapy. And in diabetes, there is no difference. Continue dual antiplatelet therapy for 12 months in case of ACS, whether the patient is diabetic or non-diabetic. So, as I said earlier, the prolonged use of DAPT among patients should be considered when if there is a risk for stent thrombosis or a recurrent event is high, then consider giving DAPT therapy even after 12 months, calculating DAPT score. So, and consider among patients who have peripheral arterial disease, try to consider dual antiplatelet therapy even after 12 months. In stable coronary artery disease patients, even if the patient dual antiplatelet therapy should be considered among the patients who have underwent after 6 months, even after 6 months, if it is a complex PCA. So, what are the conclusion? One, SISU approach for DAPT duration is unlikely to fit all patients. In ACS, we know 12 months of therapy is indicated. If it is a bleeding risk is high, consider 6 months therapy. In case of diabetes, we know 12 months therapy is indicated. Whenever you are intervening CEBG patients with venous graft, the chance of ISR is more. Try to go for 12 months therapy. Always try to specify your dual antiplatelet therapy, because our aim is not only to prevent ISR but also to prevent future events. Non-stented, non-target lesions are also very, very important in terms of patients not coming back to us with another ACS event. So stent platforms nowadays are differing, and they have become thin stents, biodegradable stents, where polymer-free stents. A lot of stents are available. So all stents are not same. Each stents have their own quality in terms of stent restenosis rates. So you can decide upon your dual antiplatelet therapy duration depending upon the stent used, where did you use the stent, how many stents are used, and whether they are proximal stents, whether they are left main stents, depending upon the nature of being stented, number of stents, and the complexity of the procedure. And obviously the interventional cardiologists know how was the result post procedure. So this all determines the duration of dual antiplatelet therapy. Though a lot of RCCT are available currently with us to decide on dual antiplatelet therapy, I strongly believe dual antiplatelet therapy duration, the choice of antiplatelet, all has to be individualized for each patient depending upon his risk for a recurrent event and the risk of the for bleeding, as well as the type of the procedure which he undergoes. Thank you for your patient listening. Thank you all.
Thank you, Vinod. Vinod, you had given a very, very good disclosure about all the drugs, the duration, everything. Now, I have a lot of reservations. The first question I asked was which drug is going to be the first among the equals, and you came up and said that you have to choose horses for courses. So you have to decide on the situation and come up with it. Now, first thing I want to ask you is, you have a patient with ACS in practical parlance, and you take the patient to the cath lab, probable enzyme elevation, and you are taking to the cath lab, not loaded, probably taking clopidogrel. On the cath lab, when you want to do an angioplasty, what would be your choice of antiplatelet drug?
I usually load with ticagrelor, 180 mg. I crush, even in the lab, I load ticagrelor.
Why didn't you use prasugrel? I'll tell you why I asked you this question. According to your own slides, the duration of onset of action is 30 minutes with prasugrel and 90 minutes with ticagrelor. If you want immediate action, you're choosing prasugrel. Why aren't you using it?
So the comfort of the drug is also important. The bleeding risk is slightly high with prasugrel, and we have been using ticagrelor in a crushed format, and we have been loading even in the cath lab, and we find even our stent thrombosis rates are not gone up. But actually, we can even consider prasugrel in that case. One of our consultants is using prasugrel when among the two. But previously, there is a cost constraint. The prasugrel was out of patency and ticagrelor was in patent. So the cost was a major consideration. When the patient is not able to afford ticagrelor, I used to load them with ticagrelor. But nowadays, prasugrel. But nowadays, I prefer ticagrelor over prasugrel.
Murli, who was stretching so long, has woken up the moment we started discussing prasugrel and ticagrelor. I can notice that. Two questions here. Now, the point is, there have been head-to-head trials for prasugrel and ticagrelor, and different studies have shown different results. If you have a STEMI, what will you prefer? If you have an NSTEMI, what will you prefer? What about head-to-head trials? Any comments?
Sir, STEMI, ticagrelor, sir, straight away. NSTEMI, if they are loaded with clopidogrel, I will do an angiogram, then think whether I'm going to do a culprit lesion plasty or I'm going to send for a CABG. Then, depending upon the choice, then I load the patient.
Beautiful. I think you guys have been doing a lot of genetic studies to find out the efficacy. But is it really useful? There was one paper.
Sir, what I understand is a lot of patients are tending to be clopidogrel resistance. Most of the patients are contributed by Murli sir only. A lot of patients are turning out to be clopidogrel resistance, but there are two types. One is homozygous and heterozygous. If it is they are heterozygous, then even though they are clopidogrel resistance, it comes. But we have been putting them on clopidogrel. Patients on clopidogrel are doing fine only. But we don't, if we found a homozygous, both the alleles are positive for clopidogrel resistance, then we usually don't put them on clopidogrel. We switch over them to other drugs. Probably if they are not affordable, initially we have been putting them on prasugrel. So this is our strategy, sir. And we are seeing a lot of clopidogrel resistance. But how far? But if you see patients, platelet reactivity test, it is going good only. We don't see that what we are seeing as a report, it is not translating in as a stent thrombosis or acute when the patients are loaded. That is what I'm seeing.
Yeah.
Murli, you want to add something?
Yeah, see, the issue is, first point, the genotyping or CYP2319 can others down the, I think there won't be an echo. The genetic typing is not being recommended by anybody, number one. So it is, I won't endorse for it. We do it, we thought we learn from it, we'll do it. One thing I have learned in that is it helped me to identify patients who are overreactive to ticagrelor. Some of the patients who had bleeding complications, minor, major, near fatal, all of them had more than 95% inhibition of ADP-mediated platelet aggregometry. Less than 10%, put them to high risk. So, given a choice today in my practice, if I do a genotyping, I mean ADP aggregometry and genotyping, I land up in two sets of patients. One is patient who are clopidogrel resistant. Other one is by ADP aggregometry, ticagrelor overreacting patients. I'm caught in between actually. But one thing, the people who are clopidogrel resistant, the studies again and again have shown we could not come to a conclusion. Yeah. Whether you are having homozygous, heterozygous, the outcome has not changed. We are yet to see an outcome-based trial where genotyping going to decide whether to give clopidogrel or not. Though we tend to avoid.
There is a trial called Popular Genetics trial, which has shown if you go for, let me finish. Popular Genetics went by a prasugrel or ticagrelor versus a genetic-based clopidogrel, and they found out the biggest advantage in that trial is the bleed was less when you use a genetic-based clopidogrel, but the efficacy was as good as prasugrel or ticagrelor.
That's what.
This is the only trial that showed it. But again, there was another trial which used only clopidogrel, genetic-based and non-genetic-based, and they found out it was not useful. So there is a conflict of point here. One of the interesting points that about this particular talk that he gave was, every time you have a talk on antiplatelet agents and dual antiplatelet, you are always wondering which drug the company is going to favor, who's going to be the sponsor. Interestingly, this company has got all three drugs. So I actually asked them, which drug are you guys trying to favor? They said that we are all three drugs. Any drug is good for us. That's the interesting part. Now that brings us to the next question. Now, interestingly, clopidogrel, yes, there is a role for it, but there is not. It's the genetic testing is plus or minus. Fine. But the next question of comparison of ticagrelor and prasugrel, there have been three major data. The first trial was the Prague, which clearly showed in STEMI there was no difference. Then there was another trial called, I think, the Revive or the Revival, something in R. That showed in NSTEMI that prasugrel was superior. Then the big, great ISAR-REACT came and said, ISAR-REACT was a very interesting trial. Actually, the aim of the study was to prove that ticagrelor was superior to prasugrel, and it went south. it went ahead and showed that prasugrel was superior. Not only that, the bleed was less. Now, there are a lot of caveats in that study. There are a lot of problems because at the end of at discharge, 20% of the patients were not on the concerned drug. And the end of the study, nearly 1/3 of the patients were not taking the drug. So the trial is very skewed. It's a little questionable, but the point is prasugrel cannot be undone. Prasugrel is a wonderful drug and it acts very fast. And based on these two trials, actually what has happened is the European Society of Cardiology, which you've been quoting throughout your study, the Europeans have said, you don't have to load the patient in emergency. Once you know the anatomy, you can load the patient, and prasugrel has taken a class 1 indication. The indication for prasugrel has gone higher than ticagrelor in a patient where you're taking for an intervention. So that's something that's happening inside. So you can think about it there. The next point that you have made is about the duration of antiplatelet. I think most of us will agree that 12 months of dual antiplatelet therapy is correct. So when do you select the dual antiplatelet therapy? I think the European Society of Cardiology, what you're quoting, has given one specific high risk and moderate risk subgroup of patients. The high risk patients are those with multivessel disease and recurrent MI, chronic kidney disease, and diabetes. So you have any one of these four with the multivessel disease, it's a high risk group. Those are the patients, if they don't have a high bleeding risk, they are going to clearly benefit from dual antiplatelet therapy or dual antithrombotic therapy, as you beautifully put what Dr. Sivakadaksham clearly said. So it's going to be multivessel disease, recurrent MI, PAD, diabetes, or CKD. If you have one of these four, you can go in for a long-term dual antithrombotic therapy, wherein rivaroxaban comes in. So which one to choose? That is where the next question comes in, the safety of the drug. If you look at the safety of the drug, the number needed to treat and the number needed to harm comes into the picture. The number needed to treat in case of in the case of rivaroxaban was 84 and the number needed to harm was 81. We are saying that the bleed was high, but most of the bleeds were not fatal bleeds. Any major and minor bleeds were high, but non-fatal bleeds. That is one. The second point is the next drug that comes is Pegasus. Pegasus number needed to treat was 77 with an 84 of number needed to harm. It's fairly safe. Pegasus is fairly safe. The concept of Pegasus is exactly what this indication for a high vessel high risk patients are. But which is the safest drug? The safest two drugs based on the DAPT and the other trials that you've been quoting have been clopidogrel and prasugrel. The number needed to treat was 63. Number needed to harm was 105. So if you have a patient with a slightly higher risk of bleeding, clopidogrel is going to be the drug of choice. So you have to decide on the choice. But if you want the best efficacy, probably you're not going to look at that. You're going to be probably looking at high-risk patients like heart failure and diabetes, peripheral arterial disease. But there's one subgroup, the peripheral arterial disease subgroup, where rivaroxaban has been fantastic. So if you have a multivessel or a polyvascular disease, the rivaroxaban is probably going to be the drug of choice. So I think the horses for courses concept is a lot more complicated than what we think it is. You just have to select your patient, choose carefully, and go ahead. Only go ahead.
Sivakadaksham, sir, can we take one or two questions and
after Murali's comment? After Murali's comment. Yeah.
Thanks for confusing very clearly. The way I say, as a quarter, as we are coming to that at the end, we know just mention about Twilight trial. Twilight, same subgroup what you are saying, enough after 3 months. Ticagrelor enough, they have shown. We are looking at it. The problem is, I tell you before we close, the problem is we are looking at numbers, we are looking at data, and we are looking at the risk-benefit ratio only to go up and down, up and down. It is not benefit alone, it's not risk alone. So if a benefit comes on, the bleeding risk remains almost same in most of the trials. Number one. Number two, I always tell in every talk, platelet activity is only one component of acute coronary syndrome. And platelet inhibition never makes the entire platelet of the body dysfunctional. We never cause that. Number three, platelet in atherosclerosis is 3 factors: adhesions, aggregation, and activation. Unfortunately, the first point, adhesion, we don't do any drug to inhibit. So what we are saying is we want to give trials after trials, industry comes in, data goes in. But the fundamental pathophysiology we haven't addressed fully, we may not be able to address fully also. We need platelet, we need clotting also. That is what the problem is. So we can keep on talking on this one or the other, but the fact is an acute clinician should look into it. I have had patients who are ticagrelor high bleeding risk, clopidogrel not all working, and I can't give prasugrel after 12 months. No guideline suggests me that. I don't know what to do, but we continue prasugrel. So these are the confusions. So it's more and more complicated. I think by trying to say you are confused clearly, I am adding to the confusion much more clearly. Thank you.
One point to that is the ticagrelor 60 milligram. In fact, one of the interesting things that he mentioned was that beyond 1 year, it might be sensible to stop the aspirin and continue only a P2Y12 inhibitor. That is also sensible. Because there have been a few trials which have actually shown that you can have a stenting with just prasugrel. The ASCET trial came, where they never used aspirin. In a stable coronary artery disease with an elective angioplasty, they just gave ticagrelor and nothing happened. Patients were as good as dual antiplatelet therapy. So there is a lot of questions. The aspirin came first, so it is still sticking on. We may have, maybe next year if we have this discussion, we may not have aspirin at all. So that's then, like, you are adding more confusion, I'm adding some more confusion. There's one question in the chat box. I'll just ask that to Vinod. It says that onset of loading dose effect is the same as 30 minutes for prasugrel and ticagrelor. Your comment on that?
So 30 minutes or 90 minutes actually. But they say in ticagrelor, if you crush and give, the action might be faster. So it is always nowadays post plateau trial. Now what we are doing is we crush the drug and give it to the patient. So they say the action becomes 30 minutes or 45 minutes. But the initial metabolism is only 90 minutes.
I think that's good. Murali, you want to give a summary? We can go ahead.
Yeah, I think very nice thing, beautiful discussion. Well summed up by Vinod also. Plan is use your drug based on the patient. Remember to use precise DAPT score and DAPT score whenever possible. You will be right, at least ethically and legally, but apply your mind before deciding. And rivaroxaban is emerging as a very good combination for dual pathway inhibition therapy. Time will come to establish it in maybe the next few years. I think we can close down because the next session is waiting. We are all here. We can participate in that session. I think we are running out of time. Thank you.
Thanks, Murali. Vinodkumar, and thanks, Prabhakar, for wonderfully having summed it up. And whenever there is a meeting on DAPT, we used to wonder why again on DAPT. Today, it's very clear that any number of meetings will only add to clarity and confusion, so that we'll continue to learn more. The next person who is going to chair the next session is the apt person who is an intensive practitioner of lipidology and also peripheral vascular disease. Dr. Manu Varma from Ernakulam. And being a lipidologist, he is the right person to take up this topic and discuss with all of us how low is too low. Because every day there is an emerging LDL level. 160, 130, 100, 70, 50, or less than 50. So today, by the end of these lectures, I think we will be able to know which is the best level at which we can keep and what is the best drug that can be used or what are the drugs that can be combined. And Manu Varma has got the greatest experience as a lipidologist and peripheral vascular intervention, and therefore he'll be able to add a few points. If they've got a peripheral vascular disease, is there any newer drug like PCSK9 which can be used for some time also? And Dr. Manu Varma, please. So you have to unmute, Manu.
Yeah. Hello, good evening, dear friends. From miracle trial to COVID 2022 trials, whether it is an acute coronary syndrome or a chronic coronary syndrome, the statins became the cornerstone in the management of coronary artery disease. And high intensity statin is the tune of the day. Definitely, if you look at the statins trials, all the clinic, even though evidences are there, all the clinical benefit translated only after 1 year of therapy. So prolonged duration of the therapy is also important. We have multiple agents, which is added therapy to the statins to reduce the numbers. But whether they have independently reduced the cardiovascular events or only a symbiotic benefit, that is one thing which we really has to find out by elucidating the different trials. And now we have got new molecules from Odyssey trials and Fourier trials, I showed Dagurokumab as well as Evolocumab. And similarly, Ezetimibe is also there. In a Reduce trial, I showed a newer molecule like isopentyl ether. So different molecules are there in the treatment armamentarium. To discuss about these issues, we have a wonderful moderator who is Dr. Sheeba George. She's a respected senior interventional cardiologist at Jubilee Memorial Hospital, Toronto. She's an alumni of Government Medical College. But what I would like to talk about is she's equally skilled in negotiating a catheter in the cath lab, as well as a strings of the vena. Painting different pictures on the canvas, also trained a classical dancer. And above all, an excellent poet who has penned down many poetries in Malayalam as well as in English. Published a book way back in 2007, 2008. Am I right? I don't know. The Agony of Innocence. We, Kerala CSI, are very fortunate to have her along with us amongst, and very proud of her. And definitely, she's an apt person to talk about or to moderate the session. And she will introduce the next speaker, Dr. Sujay Renga. Welcome you, madam.
Madam, you have to unmute.
Yeah. Good evening, everybody. Thank you, Dr. Manu Varma, for those beautiful words. Okay, I think we are running short of time. So we have to start the second session. The first session was so interesting and very vivid. We had a lot of new knowledge thrown by the speaker and the moderator and chairperson. So now we have another very interesting topic. We know that all patients who have had an acute coronary syndrome do have a high risk for subsequent events. So how to prevent these events is a real issue and a challenging issue. And we know that statins will help in preventing subsequent events. But is it because of the lowering of LDL alone that statins do this effect, or because of its pleiotropic actions? We have to know. Also, how long we have to bring down the LDL cholesterol to achieve clinical benefit. This has always been a real doubtful issue. So earlier it was, our aim was to keep it below 100 for a patient who have had an acute coronary event. But later it came down to 70. Now data say we can go down further. But is it safe to keep such low values for long term in view of other systemic involvement like dementia, neurological problems? So we have to listen to this next session to learn how low we can bring down our LDL cholesterol. For that, we have a very excellent speaker, Dr. Sujay Renga. He is a senior interventional cardiologist from NS Memorial Institute of Medical Sciences, Kollam. And he is a chief interventional cardiologist. He was a chief interventional cardiologist at Bishop Benziger Hospital, Kollam. He was a consultant interventional cardiologist at Baby Memorial Hospital, Calicut. He worked as assistant professor in cardiology at Trivandrum Medical College. He has been a consultant interventional cardiologist at Medical College, Pariyaram. And then I understand that he has good hands-on experience in treating in not only interventional cardiology, but also in electrophysiology. He has had his training under Dr. Peter Thomas, and also he has a diploma, a postgraduate diploma for medical ethics or something from the Symbiosis University, Pune. He has his DM from a prestigious PGI Chandigarh. And above all, now I know him as a good propagator of physical fitness in our CSI group. So I welcome Dr. Sujay Renga to this meeting. And Sujay Renga, the floor is yours. Give us deliver your lecture now.
Good evening, distinguished chairperson, moderators. We are friends from across the state and probably in neighboring states also. We are all fighting an invisible enemy And it is gladdening to see the smiling faces of our colleagues from the state as well as from our neighboring state. And it was exciting to listen to the talk on dual antiplatelet therapy. So it is my talk which is standing in the way between a beautiful dinner which has been properly been delivered to all of our houses. And so I'll make it very crisp and short as possible. So I'll just discuss 3 important points on what is the evidence for low LDL levels, what is the need to achieve low LDL levels. As Sheeba Madam told, is there an issue with achieving going so low on LDL levels, and what do the guidelines say? I'll start with the clinical scenario. This is a patient, a 50-year-old male, diabetic hypertensive. He had acute antiviral MI in 2019, underwent a primary PCA to LAD, and he was on dual antiplatelet, but again had a recurrence. He had inferior MI in 2021 during the COVID times. So he was initially thrombolized and then later taken up for elective coronary angiogram, and PCA electively was done to the right coronary artery. He is on dual antiplatelet, beta blocker, AC emitters, and he is on atorvastatin 40 milligram. And his lipid profile showed a total cholesterol of 110, an LDL of 69, and HDL of 30, and a triglyceride of 200. So he's on the optimal dose of statin therapy. As per the 2013 ACC-AHA lipid guidelines, long time back, which actually said that you should give statins to only 4 group of patients. 1, patients who had an atherosclerotic cardiovascular disease, 2 people with an LDL cholesterol of more than 190, 3 diabetes in the age group of 40 to 75 years, and 4 people who have a high risk of future atherosclerotic cardiovascular disease events. And the epidemiological studies from 1950s to 80s showed that there is a close link, almost linear relationship between the cholesterol level and the incidence of atherosclerotic cardiovascular disease. And the subsequent statin trials from the 1980s to 2000s showed that a decrease in cholesterol level with the use of statins can bring down the atherosclerotic cardiovascular disease events. And we all know that LDL is involved in every stage of atherosclerotic plaque formation, right from the endothelial dysfunction to formation of fatty streak, to formation of the vulnerable plaque, the plaque rupture, thrombosis, and production of both the stable as well as unstable coronary syndrome. So LDL is the key culprit there. And studies have shown that LDL is a major contributor to the cardiovascular disease. The various secondary prevention trials showed that there is almost a linear relationship between LDL cholesterol levels as well as the cardiovascular events. And intravascular ultrasound studies have shown that LDL cholesterol level is closely linked to atherosclerosis progression in coronary arteries. And that's why the concept that the lower the LDL, the better, the lesser the relative risk of coronary heart disease. And we have a lot of drugs which can produce decrease in LDL cholesterol levels. The primary drugs are, of course, the statins, which can be used as a low intensity, moderate intensity, or a high intensity statin. A high intensity statin is one which produces a decrease in LDL levels by more than 50%. And you have non-statin drugs which have shown evidence to reduce cardiovascular events, that the ezetimibe, which can produce a 20% decrease in LDL cholesterol level, and the PCSK9 inhibitors, which can produce the highest, the maximum 60% decrease in the LDL cholesterol levels. And when we combine these drugs, so if you combine statin with an ezetimibe, you can get a 65% decrease in LDL cholesterol level, and to a maximum of 85% if you combine all the 3, statin, ezetimibe, and PCSK9. So we have potent drugs which can reduce the LDL cholesterol level to whatever level we want. And the cholesterol treatment trials collaboration has shown that the meta-analysis has shown that compared to controls, moderate intensity statin can produce a 21% relative risk reduction per millimole per liter decrease in LDL cholesterol level. And if you give high intensity statins and reduce the LDL cholesterol level to further lower than 70 milligram per deciliter, that produces a 16% additional relative risk reduction for every 0.5 millimole per liter decrease in LDL cholesterol level. So if you combine these two together, there is almost 33% relative risk reduction for every 1.5 millimole per liter decrease in LDL cholesterol levels. So 2 to 3 millimole per liter LDL cholesterol level can produce a 50% decrease in atherosclerotic cardiovascular disease events. If you look at the different trials of statins, the TNT, Jupiter, the Prove It trial, all of them showed that the lower the LDL cholesterol level, lesser is the major cardiovascular event, be it in secondary prevention or in primary prevention trials. And this meta-analysis of statin trial showed that patients in the lowest category of statins. If you look at the graph, the patients who have an LDL cholesterol of less than 50 and compared to patients who have an LDL cholesterol level between 50 to 75, those with less than 50 have a significantly lower risk compared to patients in the category of 50 to 75 milligram per deciliter. So the lowest quartile of LDL cholesterol level produces the maximum decrease in major adverse cardiac events. But despite these achievements in reduction in LDL cholesterol level, there still remains a residual cardiovascular risk even with higher intensity statin therapy. So higher intensity high dose statin therapy produces a significantly lower LDL cholesterol than moderate statin therapy. It produces a decrease in cardiovascular event, but even in such patient, there is still remains a residual cardiovascular disease risk, and research is on to further target this residual group. And that's why we look at further lowering of the LDL cholesterol level, and we look at non-statin strategies. From the IMPROVE trial, we found that if you add ezetimibe to statins, there is an additional LDL cholesterol reduction of almost 20%, which translates to a 6% decrease in cardiovascular events. And we have the PCSK9 inhibitor trials, the 4-year trial with the evolocumab. Compared to placebo, evolocumab produced almost 60% decrease in LDL cholesterol levels. There is a significant decrease in primary composite endpoints of cardiovascular death, MI, stroke, hospital admissions, TIA, coronary revascularization, as well as the key secondary endpoints of CV death, MI, or stroke. And if you look at the different subgroups, the patients who achieved an LDL cholesterol level of less than 10 had a hazard ratio of 0.69 compared to those with a LDL cholesterol level of between 70 to 99. So there is almost a linear relationship between the adverse cardiac events and the LDL cholesterol level achieved. And the intravascular studies in GLAGO trial on evolocumab showed that patients who received a combination of statin with evolocumab had a significant lesser percentage atheroma volume, and they produced lesser progression and more regression of the atherosclerotic plaque in the coronary arteries. So a combination of statin with PCSK9 produces significantly more regression of atherosclerosis. So a meta-analysis was done on non-statin trials, including IMPROVE, REVEAL, and 4-year trial of more than 50,000 patients. And the control arm had patients who had an LDL cholesterol level between 60 to 70. A total of around 10,000 major vascular events occurred, and they showed that the non-statin therapy further lowered LDL cholesterol level by 0.3 to 1.2. That is around 10 to 45 milligram per deciliter. And so a decrease in LDL cholesterol level from 60 to 70 by around 40 produced additional decrease in major vascular events. So there is the residual risk can be tackled by adding the newer non-statin drugs. So there's a consistent relative risk reduction in major vascular events per further reduction in LDL cholesterol in a patient population, starting as low as a mean of 63 milligram per deciliter to achieving a level of around 20 milligram per deciliter. So if you go really low, then the vascular events also come down. But is there an issue? No, we are born with an LDL cholesterol of between 30 to 40 milligram per deciliter. Patients with hypo-beta lipoproteinemia and A-beta lipoproteinemia have very low cholesterol levels. The concerns are whether it affects the metabolic functions which are reliant upon cholesterol, such as gonadal hormones or adrenal function, whether it affects transport of fat-soluble vitamins. Our neurons have cholesterol as the envelope, and so does it affect neuronal transmission? Does it lead to cognitive impairment? There have been some post-market reports of statin producing some ill-defined memory impairment, which are reversible upon statin discontinuation. There are some observed studies which have described the cognitive effects. PCSK9 trials have shown that there may be some neurocognitive effect, although it is not statistically significant. And that's why FDA has given a boxed warning, warning both the patients as well as the treating physicians about the possibility of memory loss and confusion, which have been reported with issues, and it has advised the patients and clinicians to be aware of this possible side effect. And then we have some Mendelian randomization studies done in patients with low LDL cholesterol, PCSK9, HMG, GCR, genetic variation, and the risk of neurological disease. And they found that there is some increase in Parkinson's disease in patients in the lowest quartiles of LDL cholesterol levels. So does this translate into drug-induced decrease in LDL cholesterol level was the concern. But this was a meta-analysis of randomized control trial, which specifically looked at whether statins impair cognition, and they found that compared to placebo, there is no significant impairment of cognition in patients who are put on statins. And Evincos was a study which specifically looked at patients on evolocumab, whether it affects neurocognitive functions. It looked at various functions like spatial working memory, paired associated learning, and various tools, and found that when you compare with placebo, evolocumab did not produce any significant worsening of the neurocognitive function. And this was mirrored in other meta-analysis also, which showed that the neurocognitive dysfunction, although numerically more in patients on PCSK9 inhibitors, was not statistically significantly different. And there is a pooled data from randomized controlled trials with alirocumab, which again looked at various side effects like neurocognitive events, drug-induced diabetes mellitus, ophthalmological events, cataract, hepatic disorders, and it found that cataracts are statistically significantly more in patients who have an LDL cholesterol of less than 25 compared to patients with a more than LDL, compared to those with an LDL of more than 25. But all other side effects like neurological events, neurocognitive disorders, and diabetes mellitus was not significantly different in those with an LDL cholesterol of less than 25 versus more than 25. So no significant worsening of neurocognitive impairment there. And they also looked at the levels of fat-soluble vitamins, the vitamin A, D, E, K, and found that the vitamin levels were overall similar in patients with the LDL cholesterol level less than 25, and even with in patients who had an LDL cholesterol of less than 15. So there is no significant impairment of the metabolism of the fat-soluble vitamins. So that probably takes away the confusion. But then these are not long-term data. We don't have very long-term data on PCSK9 inhibitors as we have with statins. But whatever is available is promising and says that there is no significant neurocognitive impairment, even with extremely low levels of LDL that we achieve with these drugs. And so the ACC/AHA updated the guidelines in 2018. And now they say that in patients with clinical atherosclerotic cardiovascular disease, patients can be categorized into very high risk and not very high risk. In patients who are very high risk, you give them a high intensity, straight away give them high intensity or maximal tolerant dose of statins. And if the LDL cholesterol level remains more than 70, then you can consider adding an ezetimibe. And if still the LDL is more than 70, you can consider adding a PCSK9 inhibitor. So the LDL levels, that is the only LDL level that the ACC/AHA guidelines talk about is that it should be less than 70, and if it is not maintained less than 70, you add the non-statin drugs. And in primary prevention, you should focus on patients who have an LDL of more than 190, same as the earlier guidelines. People with type 2 diabetes mellitus, you start on moderate intensity statin, and patients with atherosclerotic cardiovascular disease. And in patients who are more than who do not have either atherosclerotic cardiovascular disease, familial hyperlipidemia, or diabetes, you divide them depending upon the Framingham risk score. And people with a high risk and intermediate risk score can have a statin upfront. The 2019 ESC guidelines are more clearer in terms of the LDL levels. They divide the patient into 4 different groups: a low risk group, a moderate risk group, high risk group, and very high risk group, depending upon a scoring system. And if all the patients with atherosclerotic cardiovascular disease are in the very high risk group, people with a risk score of more than 10% are in the very high risk group. Those with a family history of atherosclerotic cardiovascular disease with another major risk factors, people with an eGFR of less than 30, diabetes with endocrine damage and more than or equal to 3 major risk factors, all of them fall in the very high risk group. And in the very high risk group, the target LDL level should be less than 55 milligram per deciliter. So less than 55 milligram per deciliter. In patients with high risk group, it should be less than 70. In moderate risk group, it should be less than 100. So the target that in atherosclerotic cardiovascular disease, the ESC guideline recommend is a level of less than 55 milligram per deciliter. And for atherosclerotic cardiovascular disease patients who experience a second vascular event within 2 years, that is similar to the patient in our clinical scenario where a patient had a recurrent inferior MI within 2 years. In such patients, an LDL cholesterol goal of less than 40 may be considered. So you can go up to even less than 40 in patients who are in the highest, extremely high risk group who had frequent recurrent cardiovascular events. And we have the latest guidelines would be the 2021 Canadian Cardiovascular Society guidelines, which similarly categorize the patients into low risk, intermediate risk, and high risk depending upon the Framingham risk score. More than 20% risk means you are in the high risk group. And patients in the high risk group, you initiate the patient on statin treatment. And if you are not achieving the LDL cholesterol levels of less than 2 millimole per liter, that is less than around 85 milligram per deciliter, you can add an ezetimibe as the second line agent. Or they also say bile acid sequestrants as an alternative. And in patients with atherosclerotic cardiovascular disease, it is always patients are started on high intensity statin therapy. And if the LDL cholesterol remains more than 70, then you can consider adding ezetimibe followed by PCSK9 inhibitors. And these guidelines also talk about triglyceride levels. When the triglyceride levels are more than 150 to 500, they recommend to consider adding isopentylate 2 grams twice daily. So depending upon, based on the current evidence, the guidelines have been modified to newer LDL target levels. So to conclude, we are born with an LDL cholesterol level of 30 to 40 milligram per deciliters. Hunter-gatherers had the low LDL cholesterol level with very low prevalence of CAD. Extreme risk group is an additional ASCVD risk category indicating greater atheroma and greater MACE, and these patients need more aggressive LDL cholesterol reduction. Extremely low levels of LDL can be achieved with newer drugs and should be considered as an option in this extremely high risk group. Maximum tolerable dose of statins with or without ezetimibe, adequate lifestyle interventions, and treatment of all modifiable risk factors must be looked into carefully prior to addition of newer, much costlier drugs like PCSK9 inhibitors. And identification of the highest risk group would benefit from maximally with efficient drug therapy is probably the most important key that we should be looking at. But however, the final decision should always follow a detailed discussion between the patient and the treating physician. Thank you very much for your patient listening, and I hope that all of us stay safe from the pandemic. Thank you.
Thank you, so Dr. Sujay Renga, for the beautiful disclosure. Are you in practice trying to achieve this low levels of less than 50 in your practice as an interventional cardiologist? And how low would you go? And do you think patients accept these low levels, because our Malu population are well known to Google all these things, and they they have a lot of quotations than us, though it is not from the scientific world.
Yeah, probably, so, madam, our patients probably listen more to the pharmacist from where they get the drug. So usually the pharmacist tell them that your LDL cholesterol is too low and your doctor has given you an overdose of medicine. Correct. And you should cut down on your tablets. So our practice would be in patients who have an acute coronary syndrome, at least in the first 1 month, we try to give them the maximum tolerable dose of drug. And you look at the LDL levels after 1 month, and then treat them according to what is their LDL, how much LDL reduction have they achieved. Now, it is easy to talk about guidelines, but it's difficult to practice in our routine daily practice. But in patients who have extremely recurrent events, very frequent recurrent events, I think we try to go really low. But combining the need to combine ezetimibe with atorvastatin is not very frequent, and we usually achieve low LDL levels even with an atorvastatin of 80 milligram or rosuvastatin of 40 milligram.
Correct.
Ma'am, can I make a comment? Dr. Sheeba.
Sure, Dr. Prabhakar. Hi, nice to see you.
I think probably the first time we are meeting inside India.
Correct.
Okay. A couple of things. You haven't spoken about the Lipidization of India guidelines. I'm one of the co-authors for that.
Yeah, I'm sorry about it.
As early as 2016, we have recommended an LDL cholesterol of 50. And in 2020, we came up with a guideline for the very high-risk group for 30 milligrams LDL cholesterol. One of the biggest reasons was the Glasgow trial, which you quoted correctly. But there's another slide on that which clearly shows when the mean level of Glasgow trial is actually 30 milligrams. So when you achieve 30 milligrams, you actually have reversal of atherosclerosis. That's one of the very important reasons. There are a lot of other interesting facts about cholesterol. One is you say that you want to reduce your LDL, your statin therapy after 1 month of therapy. No, you cannot do that. We started saying lower the better. Now we are saying lowest is the best. Lowest is the best, it holds good. Now there is one particular Korean trial which is clearly stated that post PCI, if you start giving a high intensity statin for the same level of LDL cholesterol compared to a high intensity statin or a non-high intensity statin, the incidence of MACE is higher if you don't give a non-high intensity statin. The reason is the plaque stabilization does not happen with a non-high intensity statin. So don't reduce the statin. If the patient tolerates it, why are you going after numbers? Now, Dr. Sheeba had a very, very valid point. which said that our Mallu population Googles. My population also Googles. Everybody Googles nowadays. Who doesn't Google? So the answer is, the moment you start the patient on a high intensity statin, tell them their target is less than 50 milligrams of LDL cholesterol. Once you tell them, they know, and tell them clearly that your lab values are all humbug, because the biggest caveat is the lab reference values, which says the ATP3 guideline, which is 2002. That is the biggest problem in treatment of LDL cholesterol. So you have to tell them, this is your target, that is for normal people. That helps you a lot. So I think that you have to go. And safety of LDL cholesterol is very, very important. The long-term safety of LDL cholesterol less than 30 has been proven. There is a separate article in ACC, in JACC, that came up maybe about 6 months ago, which has clearly proven it, but clearly states less than 15 in the long term is not proven. So try to keep it for the high intensity patients between 15 and 30. Another interesting point, you mentioned the European Society of Cardiology guidelines, which said that for a recurrent MI, you go for a 40 milligrams per cent. Now this 40 milligrams per cent, Dr. Iyengar, who is the chairperson of the Lipid Association of India, wrote to the European Society of Cardiology and asked them, how did you land up with this 40 milligram per cent? They did not have an answer to it. Now, if you ask me, how did he land up with a 30 milligram, the Glago gives you the answer. So once you have 55, you're not sure, land up at 30. And who are the persons who are going to benefit from 30? Those with polyvascular disease. They have multiple vascular events. Like the rivaroxaban group, this is the statin that is very, very important. The second subset is the diabetic subset. The diabetic and polyvascular disease, they benefit a lot from high intensity statin. You can bring it down to 30. I don't have the slide, but there is a Lipid Association of India guideline that was published in November or December, JAPI special issue, which shows the full guideline wherein there is an extreme risk category A and B. The category B, you try to bring down the LDL cholesterol to 30 milligrams per cent.
Hi, good evening, everybody. Can I add a point, sir?
Yeah, sure, sir.
Sujay, your talk was extremely enlightening. My recommendation is that you talk a little bit to the patient, and usually they will listen to whatever the Google says or the laboratory person says. Today morning itself, I had a patient who had an LDL value of 42. 3 months back, his LDL was 38. He had an antiviral, a young chap, 37, 1 year. He's doing extremely fine. So I was just telling that if your LDL does come down, there is an Indian recommendation that probably keeping below 40 is okay. And you have to keep on keeping it below 40. Then only your the bad cholesterol which has been laden in your blood vessels dissolve off. This is the way that I talk to them, and most of them listen to me.
Can I add something? No, this is not about lowering the LDL, but actually speaking, the acute coronary syndrome or the pathophysiology of acute coronary syndrome is not essentially it's not essentially the lipids. It is actually a triad of inflammation, insulin resistance, and oxidative stress. So keeping LDL cholesterol to the bare minimum alone will not solve the issue. That's what I always feel. So there should be something which can really suppress the inflammation and insulin resistance. All of us, majority of the South Asian population have insulin resistance. So how to target insulin resistance, how to target inflammation, how to target the oxidative stress. Probably oxidative stress is taken care of partly by the statins because of their pleiotropic effect. But prevention of ACS, MACE does not depend on lowering LDL cholesterol alone. That's always what I have felt. Because I've kept LDL cholesterol low in many patients, still they have come back with heart attacks, still they have come back with even hemorrhagic stroke I have seen, ischemic strokes I have seen. So we do not have a total answer whether everything is based on the LDL cholesterol alone. So it is something more beyond that. So we have to probably target the 3 trios which are responsible for the renal vascular disease. Not simply, I think sometimes I feel, doctor population are wrongly targeting the LDL. I'm sorry to say in this platform, because the many of the patients with MI, we do not see very high LDL levels,
Beautiful
Okay.
point. Beautiful point. I'll just make a comment on that. Now, it's clearly proven that the LDL cholesterol has been traditionally studied, and that is the reason we keep talking about LDL. 1 month ago, there was a beautiful paper from the Copenhagen group. From that study, they studied and said non-HDL cholesterol and apolipoprotein B are much superior targets. So non-HDL cholesterol is otherwise called as poor man's apolipoprotein B because you have to assay it separately. So you not only take care of the LDL cholesterol, but there is something called the remnant cholesterol, which is the cholesterol content of the triglycerides, lipoprotein little a, and the other factors. So don't go after LDL cholesterol. If you look at all those patients, they will have a non-HDL cholesterol that's high. Routinely in my clinical practice, I do apolipoprotein B for all secondary prevention patients. Because once you have achieved LDL cholesterol, if the apolipoprotein B has not achieved target, it's called a discordant factor. If it is discordant risk factor, then they are high risk. They are the patients who are more prone for heart disease. Concordance is when both are low. Both the LDL is low, apolipoprotein B is low, it is fine. You have a discordance. Sometimes it's discordant low risk where the ApoB is low and the LDL can be low. Because ApoB is the particle that binds to the vessel wall and creates a problem. Now, if you want me to confuse you a little more, like Murli says, I can give you one more factor. Murli, shall I?
Yeah,
Sir, one way you are treating those patients.
I'm entering. Give it.
Sir, those patients, Dr. Mangal Anandan, it's an excellent question. Now, what you have to do is you have to intensify the statin because they are the patients who are more prone for coronary artery disease. Now, I have a data of about nearly 2,000 patients on apolipoprotein B and this thing, and I have found out this discordant pattern and concordant pattern. The patients who do the best are those who actually achieve an ApoB value which is less than LDL cholesterol. Very rare, but it does happen. Now, I am a big user of high intensity statin. I use 40 milligrams of rosuvastatin extensively. The lowest LDL I have in my clinical practice is 19 milligrams. They're all fine.
Yeah.
PCSK9 I hardly use much. Now, if you want me to confuse you a little more, there's something like more interesting, like the small dense LDL and the large dense LDL, which is actually not the small dense LDL and the large dense LDL. If you see it more carefully, there are two types of LDL: cholesterol rich LDL and cholesterol depleted LDL. Okay. Now, the cholesterol depleted LDL and the cholesterol rich LDL work differently. The cholesterol rich LDL gets into the vessel wall, it deposits the cholesterol and comes out. So that increases the plaque volume and the atheroma increases. The cholesterol depleted LDL, which we commonly know as the small dense LDL, goes inside the vessel wall and does not come out. So what it does is, it is going to stay inside the vessel wall, promote inflammation, and it produces a plaque rupture and produces an ACS. So both are equally dangerous. So what is the common factor in both? Both have apolipoprotein B. So both are dangerous. So go after apolipoprotein B. So the final message is very simple. LDL cholesterol target, which Dr. Sujay has been talking about, you must change the topic next time and say, look at targets of apolipoprotein B.
Yeah. Prabhakar, your apolipoprotein B, both 48 and 100, no?
Which one?
You are going to measure both B48 and B100.
Yeah, when you look at, practically when you look at apolipoprotein B, it comes most. But most of it is B100. B48 is hardly anything.
See, it is very easy to understand. Apolipoprotein B, there is one apolipoprotein B per cholesterol molecule, cholesterol lipoprotein. So you can have a small amount of large LDL, each will have one apolipoprotein B, and several small LDL, all will have each one apolipoprotein B. And when you measure apolipoprotein B, you are going to measure not only LDL but also on IDL. And if it is going to add chylomicrons and VLDL also, if it is going to encompass B48. But we know apolipoprotein B itself is a causative agent for atherosclerosis. That is a discordance where you get the LDL level maybe more than the apolipoprotein B, because that is a group where you suppress the other apolipoprotein B carrying lipid subgroups like IDL, LDL, everything. So given a choice, apolipoprotein B will be a better measure than LDL. No doubt at all. And interesting, as Madam said, it has been again and told, maybe a percentage increase. You make the entire world eulipidemic. I use the word eulipidemic, the entire human race. You are going to reduce the coronary artery disease only by 33 to 40% only, man. You are absolutely right. That is interesting. So if people think lipid is completely only thing, it's not like Anopheles mosquito and malaria. It is not like you kill LDL, you are going to kill CAD. That is a totally wrong notion. LDL is very useful, but interestingly, what I learned in the last 2 decades is risk factor like LDL, hypertension, diabetes, everything. Slowly, LDL is becoming a causative agent, but not only agent, madam. You are absolutely right. So our physician should go with the idea: treat LDL, but treat the patient. There are many other risk factors which can cause coronary artery disease, acute coronary syndrome. I agree there.
Totally agree with you, Murli. It's a
Madam, can
multi-faceted disease, and this is only one point.
Interrupt you?
Dr. Manu, sir, please.
See, just reduction of LDL cholesterol is not enough because we had many other agents also. But we couldn't find any translate into any significant benefit. Even if you are talking about the evolocumab or alirocumab also. They are done on the top of the intensive, more high intensity statins. So, in fact, the LDL reduction and along with statin, probably what we could get is the ancillary property of the statin also. Again, Jupiter trial showed the reduction of the high sensitive C-reactive property, whereas in the case, if you use an evolocumab or alirocumab, there is no significant reduction of the high sensitive C-reactive protein, which was again demonstrated in the EVOPAC trial. So we do not have, in fact, a particular molecule if you take other than statins, everything along with statin only, which is superior, or you can say about this will reduce with more effect. So along with statins, by reducing, we are getting the benefit. In fact, we really don't know, are we attacking the LDL is the main culprit or not. Whatever we mentioned. Regarding the inflammation and lipoprotein A, above 50 milligrams is found to be atherogenic, and you can see evolocumab and alirocumab decreases the lipoprotein A, whereas statin do not. So in fact, we need more data and more trials, as well as the individual trials, other than the, if you want to take it, the evolocumab alone, its effective is better than that of the statins. Without statins, we need to study different.
There is some data to that effect, sir. There is some data to that effect to say, and there are two things there. One is that the Lp(a) has been found to be independently predictive of coronary artery disease, even in the PCSK9 trials. There are separate papers which have proven that part. That is proven. And the second point about any other drugs, there are 2 drugs that reduce the lipoprotein A. Lipoprotein A is an exclusively Indian compound. It is supposed to be the dangerous cholesterol. So what or the ugly cholesterol. So what it can be brought down by 1, this, and 2 is the HDL elevating. What is it called?
It's a nicotinic acid. Nicotinic acid
has been proven to be useless, sir. The HPS.
Yeah, it just decreases the lipoprotein A.
No, sir. The other thing that works is the Anacetrapib also brings down the Lp(a) by 30%. So these are the 2 drugs. The other interesting fact that we are all not discussed about today, we are speaking only about LDL, is that HDL cholesterol is no longer considered important. Because what we measure as HDL cholesterol in clinical practice is the content of HDL cholesterol. It's not the functionality of HDL cholesterol.
Yeah.
But in epidemiological studies, for a given person, it has been proven to be inversely proportional to the incidence of coronary artery disease. That is there. But increasing HDL has not been proven to be useful in any of the anacetrapib or the trapib trials. So that is something that we have to be looking at in future and talking about it.
See, that is very obvious. See, as you said, HDL cholesterol, the functionality is very important. When you want to raise the level by anacetrapib or norcetrapib, by CETP inhibition, you are removing the functionality. It is like having a bank account without eating. You have a huge amount in the bank, but you don't have food. So the HDL cholesterol goes up, but it doesn't work at all. That is what anacetrapib does. So the reverse pathway itself is being inhibited to keep high HDL.
Dr. Prabhakar, if you lower the LDL cholesterol so low, the HDL also naturally goes down too much. So that is also an irony. Sometimes we feel very sorry. A person with an HDL above 55, 70 now comes back with an HDL which is less than like 18 or 17 with an LDL also which is low. So there was
absolutely don't worry about it. Absolutely. Yeah. Whenever the total cholesterol comes down, HDL will come down, but it doesn't matter. It will not create a problem. because the primary cause, because you're going to reduce it to such low levels only in secondary prevention where LDL is more important. And one of the important things is that aspirin is out in primary prevention because of statins. Statins have stabilized the plaques. Ever since statins came, aspirin is out because the original physician's trial, there was no aspirin, there was no statin. That is when they showed that aspirin is useful. So once the statin trial started coming in, aspirin has been not found to be useful. So statins also stabilize the plaque, which is the pleiotropic effect which Dr. Sujay has been talking about. So the pleiotropic effects are pretty important, and that is something that we are still not yet come to terms with. I think it's fantastic.
In Prabhakar, to add to your point now, madam, the original HDL, the breakthrough observation was HDL Milano, the village in Italy where they showed HDL protective role. That pedigree had actually HDL of around 15 to 18 only. A very low HDL, but highly functional HDL. That is how the whole HDL theory started. So the number is more important, not important. The functional is very important. But this debate was going on and on for nearly 2.5 decades now. Finally, we have come to a point, don't bother about HDL, come to LDL, which is also not fully right. We need to find a way to make HDL active, not voluminous.
It's actually gone reverse, Murli. What the European Society of Cardiology guideline last year has clearly gone ahead and said, if the HDL is more than 90, it's actually a harmful factor. Because
that is true.
That's a very high
it can be harmful.
Too low HDL or too high HDL is not beneficial. In fact, I have a patient who had an HDL of more than 70 developing myocardial infarction.
Yeah, I had two women, ladies who had HDL above 100. So I was wondering whether it's possible. So I kept on repeating in so many labs, and every time it came as above 100. So I have been following up these ladies for 25 years now. Okay. And both of them never had CAD till now. One has lived up to 88 years. Another is still living. The one who died developed a cerebral hemorrhage and died. She did not develop a CAD. And this is a strange incident, but I'm telling you, this super HDL levels. So anyway, they do not have CAD. I do not know. Still it is protective. Who knows? And another concern for women. Okay, I'm the only woman in this platform. So if you lower the LDL too low, you may, Prabhakar may laugh, the skin texture goes bad, very bad. You may feel, it is something not very important for men, but for women, we are very much worried about our looks and skin and all these things. Yeah. So, and many of the dermatologists also have told me, I have actually checked with the dermatologists, they also told me this very true. Now you cardiologists are prescribing high doses statins, and these women come back and say their skin has become so bad, the skin texture has gone down, wrinkles are coming so fast. I do not know about the scientific base, but I think that's also a concern.
Dr. Sujay, your comment on the hemorrhagic thing that he said, hemorrhagic stroke?
I'm not aware of any relation between high HDL and hemorrhagic stroke.
No, the LDL and the hemorrhagic stroke that she was talking about. Madam made a comment about that because you spoke about that in your talk. Actually, okay, let me take it. It's exactly the Sparkle trial which came up with that. In Sparkle trial, when they reduced the LDL cholesterol considerably, there was an increased incidence of hemorrhagic stroke, but the overall benefit was in favor of LDL lowering because the ischemic stroke was reduced much more than that. Ma'am, there are a lot of questions. As moderator, I think you should go ahead with a lot of questions on the chat box.
In the intervening period, I think I have replied to some of the queries.
Yeah, sure.
So that we can have a quicker dinner.
Yeah, go ahead.
And I had replied to some of the queries in the chat box.
Oh, great, wonderful.
Manu sir, if you don't mind, I think we had a wonderful discussion, and you should conclude the meeting because as the Archives of Internal Medicine says, what Dr.Sheeba has told. If you type the word, the advantages of using statin, there are 33 million articles. But if you type the word, the disadvantage of statin, there are 4 times more articles.
Absolutely.
So the skin specialist will say one thing, everybody will say one thing, but I think statins have come to stay, as evidenced by the aspirin that Prabhakar was mentioning, and definitely it is advantageous and not very disadvantageous even if it is very low, because even the PCKS deficient population, by birth PCKS deficient population, their LDL is only between 15 to 20, and they have absolutely no dementia, no neurological deficit, and no cancer increase. So that is why they said it is better to lower it. But I think as cardiologists, till the time it is disproved, we should promote the theory that lower is better. Thank you.
So, thank you, sir. Bye-bye.
Thank you, sir. Thank you
Good
very
night.
much. And
Happy to see you,
Yes,
all
sir.
of you, at least online.
Even I should congratulate Torrent. I do not know how long you have been in Torrent. For the past 40 years, they used to be initially bring a new drug at a cheaper cost. Now you have produced a very new one in the digital era. I think, to my knowledge, you are the first company who is providing dinner after a digital meet.
Sir, not only dinner,
I hope
sir,
others will follow.
sir, musical evening is also there. So I will just conclude.
Right.
I am honored and privileged to be the part of this enriching session. As we conclude this DPLAT ACS meet, on behalf of Torrent Pharma, I would like to convey my heartfelt gratitude to Dr. Sivakadaksham, Course Director, all the esteemed faculties and all delegates for accepting our invite and sharing this vast experience and in-depth knowledge with us. We are sure today deliberation will definitely help you in your day-to-day clinical practice. Now I would like to invite you all for musical extravaganza to rejoice the evening with your family members. You along with your family members are requested to log in the musical extravagant link provided to you. We are sharing that in the chat box. So you can just log in, and my colleague Yogesh will just show how to go about it. So immediately you can log in for the musical evening. Yogesh, please.
Good evening, doctors. I have shared the link in the chat box also. So this is the registration page will open up once you click on this link. After you get registered yourself, email ID and password. Once the login is done, have a look at this wonderful auditorium, this platform, and once you click on the auditorium, you will be taken to the musical extravaganza event. It is about to start. So let us join this event and click here to enter the event. So thank you, and enjoy your dinner and enjoy the musical night.
Thanks, doctor. Stay safe, stay healthy. Kindly join in for the musical event. Thank you so much.
Thank you. Good night.
Thank you, sir. Thanks.
Thank you, Abel.
Thank you, madam. Thank you so much.
Thank you.
Thank you, sir. Thank you so much. Good night.
It's a beautiful session. Yeah.
Yes. Thanks. Madam, kindly join the link.
Yeah. See, actually, I came to my flat because the net connection is good here. Now I have to go back to my house. My husband is there.
5-10 minutes, you can just log in, madam.
So,
when I reach home, I'll
Bye, madam.
Okay.
Bye, sir. Bye.
Bye, everybody. Bye.
Bye.